Hello, everyone, and thank you for joining us for this webinar on the cholera outbreak in Syria and in the region. I'm very happy to welcome you as part of the Syria Public Health Network. I'm the deputy chair of the network. I work alongside colleagues Diana Reyes, who is the current chair of the network, Aula Appara and Fuad and others. And we try to host these series of webinars to highlight key public health issues affecting Syria, but also other similar contexts like conflict-affected countries and other humanitarian crises. So in this webinar, we will focus on the cholera outbreak. We're very happy to have very prominent speakers who are specialized in issues related to infectious diseases in complex settings. And just to remind you that this webinar is recorded, just to make sure that the recording will be available on the SPHN website. And also the webinar is hosted jointly by other entities, including a project with King's College London. The project is called Research for Health System Strengthening in Northern Syria. And this project is funded by the National Institute for Health Research and is led jointly by King's College London and the Union for Medical and Relief Organizations. And also the webinar is co-hosted by the Center on Health and Humanitarian Crises at London School of Hygiene and Tropical Medicine. So I will hand over now to our chair of this webinar, Professor Samer Jabour. And Professor Samer is a professor of public health at London, at the AUB, the American University of Beirut. And he's a prominent researcher on issues related to health in Syria. He was and he's still the lead of the Lancet AUB Commission on Syria, and he has done extensive research and publications on health, on public health and health generally on Syria and the region. So I will hand over to Professor Samer, and thank you again for joining us. Please, Professor Samer.
Okay. Thank you, Karim. Hello, everyone. It's a real privilege to be here. I'm actually right now Aula Appara. I'm representing Aula Appara, who's unable to join us in hosting and moderating the session because she doesn't feel well. So we wish Aula very well. She has done all the work, the preparation, along with Karim and other colleagues at the network. So they deserve the credit. I will take responsibility for any mishaps or issues that may arise with the moderation. We have an important issue to discuss today. As I was thinking about our webinar, a visit to London came to me from early October. We were at a meeting on health and human rights, which is an issue obviously connected with the topic of our webinar today. And for the first time in so many years of, in so many visits to London, I visited the Broad Street pump where cholera history is closely connected, obviously, with its discovery. Actually, the whole history of public health and epidemiology is connected with cholera and that particular place. In that same evening, I read a report about more cholera cases in Syria. And this really brought into stark contrast how cholera really tells a story. It's a story about a story of two nations. In London, obviously, cholera became a symbol of progress. You could take a picture next to the pump, reassured that you will never see that again there. You could go to the pub right next to it and sign your name, thinking that you will enter the history books just like Jon Snow did. but it tells a very different story about Syria. It tells a story about the destruction of infrastructure, about the increased immiseration of whole communities, and it really, for us Syrians, it tells the story about our national humiliation that we have to deal with resurgent cholera, and all it tells about our country. So I'm really grateful for the Syria Public Health Network, who have been doing a terrific job in hosting these policy dialogues, in putting the spotlight on cholera. The speakers we have today are a terrific group of experts, researchers and practitioners who will be able to tell us dimensions about this story that cholera tells about Syria, but also globally. So without further ado, I'm going to start the webinar by introducing the first speaker. We're going to ask him a couple of questions, and then we are going to move on to other speakers and ask them more questions, so they can tell us dimensions of this story of cholera in Syria, as well as perhaps in other contexts affected by context and instability and fragility. Very glad to welcome colleagues that I have been following their work. Rowan Ratnaike is a field epidemiologist. He's now doing a PhD in mathematical modeling and epidemiology. And when you read his work, you get to know why he's doing PhD in this field, because he's really published a lot on this area. He's been working with on the issue of cholera with the epicenter of, which is the research arm of MSF. Rowan, thank you very much for joining us. Before we get to talk about our subject today, can you say something real brief about your work with Epicenter on cholera? Over.
Sure. Thank you for having me. I will. I'd love to keep everything brief, because I think there's a lot of good discussion that can happen among people on the call. Many of you who are well experienced with cholera. I've been working through my PhD and other work with Epicenter at MSF on targeted interventions for cholera, evaluating them in countries with ministries of health to understand whether we can really shrink these outbreaks as they're being detected, which really does relate to conflict and crisis affected areas and low resource approaches we can use.
Excellent, wonderful. Thank you very much. From your vantage point, you're at a center of excellence that's looking perhaps at a variety of conflict settings and humanitarian areas affected by cholera. So perhaps, Rowan, you could give us an idea about the current situation of cholera in its global scope, and what is it that we know about the burden of cholera, perhaps in recent history, at least, in conflict-affected areas.
Perfect. I will do so. I'm just going to share my screen. I have one or two slides to show you. Can you see that well?
Yes, yes.
Okay, perfect. Okay, so what I'm going to do today is give you a broad overview of some of the cholera trends this year and the previous year, and specifically how conflict and crisis affected countries are coping. I think it's really important to look at this in context and get a broad overview of how cholera behaves globally and how it's reported. So there's certainly, as you can see from this chart, which is from the most recent WHO report on cholera from 2021, there is certainly more cholera being reported from countries in 2021, and as we'll see in 2022, compared to, say, the previous epoch, which I would say is before 2017. This can be seen in the annual statistics on reported cases, and as we know, cholera is grossly underreported most of the time. And these are, it doesn't include all of the countries which have cholera, which may not report to WHO. But what's becoming clear over time is that some of the large spikes that we see in 2011, in 2017, and onwards, they're related to outbreaks that occur concurrently during humanitarian crises, where they start small and enlarge geographically and are very difficult to contain. So you can probably type in the chat, but the spike in 2011 is, of course, the outbreak in Haiti, following on the heels of the earthquake there and general insecurity, and a population that did not have a lot of immunity or any exposure to cholera before. From 2017 onwards, we see some pretty high bars there in blue, and that's representing some of the largest epidemics in the world, more than 20,000 cases reported per country occurring in humanitarian crises in Yemen, in Somalia, in northern Nigeria, and South Sudan. So they really sort of overtake the statistics, and we really want to know more about why that happens and why they are so hard to control. So what I want you to remember from a chart like this, and any chart you see on cholera epidemiology, is that the epidemiology really varies widely by country and area. Year to year, we might not see it in a country each year. And within countries, we might see different hotspots in that country. And the second point is that conflict is one of the few major drivers, but it isn't the only driver. And some of these drivers occur concurrently with conflict. That includes, generally population growth and urbanization in most of the big cities in the world. And then really importantly, climactic shocks, which happen year upon year, like droughts and floods. This is very relevant to the Horn of Africa, and it's also relevant to places that have water scarcity, which other speakers will speak about as well. So these really occur concurrently in conflict-affected countries while conflict is happening, exacerbating the situation and ability to control and detect these outbreaks.
Thank you, Rowan. I bet many of the colleagues looking at this, at your graph will be asking themselves, is that it's interesting to see that the cholera cases have risen sharply in recent years, but the cholera case fatality rates have continued to drop. And then there's the unexplained recent rise since 2020. So can you please explain these two phenomena?
Sure. So in general, as I was saying, the large outbreaks really tend to dominate some of these statistics that come out in terms of producing reporting of cholera cases, and just representing a wide geographical scope in a given country like Yemen, for example. But the case fatality rate is curious. It has descended over the years, that squiggly black line. But I think, what we know is that, again, deaths are really underreported. And they really do vary year upon year. It does represent, we'd like to think, better access to care, communities being closer to rehydration centers and so forth. But I think it also hides a lot of the actual true situation, deaths that don't go, ascertained as cholera. But it certainly is on a local level for anyone who's responding to cholera. It really does a few deaths really does represent a real signal that something that care and access to care isn't sufficient at all.
Thank you, Rowan. And what about this, the second phenomenon, which is the recent rise since 2020 in the case fatality rate of cholera? It seems that there's a lag between when the epidemic hit, which was really highest between 2017 and 2020, and when the case fatality rate started rising in 2020. What explains this phenomenon?
I think it remains to be seen. I think most of the deaths in 2021 came from, I believe it was northern Nigeria, which has had cholera for quite some time, probably represents an opening up of areas where there's better reporting of these deaths happening, rather than an increase in the severity of the disease, for example. I really do feel like it represents in many cases a surveillance artifact of better reporting of these deaths in certain places. But I think it is a signal to understand why are we finding so many deaths? And it might be in remote areas of certain countries that are receiving less care than you would find in, say, a Juba or a capital of a country versus externally in different districts and so forth.
Okay, thank you, Rowan. Rowan, just hold it where you are. We'll get back to you again with more questions in a little bit. I'm going to move on to our second speaker, second panelist, Mark Zaytoun from the Geneva Water Hub. Mark is Director General of this hub, and he's also Professor of Water Security at the University of East Anglia. He really has led many projects on related to water supply and water negotiations, particularly in our region. So, Mark, thank you again for joining us. You've worked as both a humanitarian aid engineer and a researcher in Iraq and Gaza and elsewhere. With the background that Rowan has provided about cholera, how does your experience shed additional light about the links between conflict, water, sanitation issues, and obviously cholera?
Sure. Thanks very much, Samar. I think Ron is dead right when he's saying there's some association between conflict and the spread of cholera, at least. What we found through our research is that, maybe some of the mechanisms that would strengthen that would suggest that association is there. And I can try to explain for the audience. I guess the takeaway message would be that there are that we should be considering the reverberating effects of attacks on water systems. So the reverberating attacks, which mean that the suffering continues long after the attack is finished and far beyond the blast zone of that attack. Mm-hmm. And so that's because, and it's not associated with this figure on your screen right now, but that's because there are a couple of things that perhaps people should bear in mind if they're going to be convinced or challenge what I'm saying. First of all, water systems, any urban water system is composed of the infrastructure, so water pumps, water treatment plants, pipes, the consumables like chlorine that can kill all the nasties in the water, and then the people that run the system that keep it going. And some elements of these systems are much more important. Not all elements of a water system are equal in that sense. If there's, for instance, a water treatment plant upstream that's serving water to 750,000 people in a neighborhood, it's more important than, say, a water treatment plant that's at a community level that's only serving 100 people. Not for those 100 people, of course, but in the larger scheme of things, the upstream water treatment plant is considered critical infrastructure and therefore should be protected in different ways. But even more important than infrastructure is people, because a couple of engineers with lots of duct tape can keep just about any system going under extreme circumstances. And if those people don't show up for work because of the security situation, or they flee the country, or the conflict has been going on for so long that they actually retire or emigrate, then the system really buckles. And so that's an indirect effect of attacks on, the brain drain is an indirect effect of conflict on water systems, and a really important one. Now, just consider, for example, getting back to the reverberating effects, and now thinking more particularly about protracted conflicts. And our research is based on Basra, Gaza, and Yemen. So the classic, if a water treatment plant is damaged, intentionally or not, it's really difficult to say, but the pumps aren't working. So there's no pressure in the water pipes that drive water up into your fifth floor flat taps. So if there's no pressure in the pipe, what a lot of people do is they put a suction pump on at the bottom of their flat to suck the water up into the rooftop tanks and then down into your taps, which is ingenious in many ways. But when you're sucking water, then you're also sucking in all the stuff that's around the pipe as well. And if there's any wastewater, especially cholera-infested wastewater, then you're sucking up that water. And before you know it, you're bathing in, if not drinking, other people's feces. And so our research would make an epidemiologist cringe, but we suggest that there's a strong association between when you see that situation, cross-contamination of water and wastewater, and you see the number of cholera reports in a hospital, there is an association. The other thing I would ask your viewers to remember, I think, is, and this has implications for what do we do about it. The longer the conflict goes on, the more predictable these effects are. So more predictable because the system gets damaged and weakened, and all these coping mechanisms increase, and the likely spread of cholera is more likely. But also, what's interesting here, and this has implications for international humanitarian law, because it's more predictable, it puts, or should put, more of an onus on the people who are doing the attacking, so the combatants, to consider the reverberating effects when they're conducting their proportionality assessments or targeting assessments.
Excellent. Thank you, Mark. Mark, so you've already kind of in direct ways alluded to what can be done about cholera in context of conflict or even before conflict. But perhaps you can more directly talk about some of the measures that you think would be important to reduce or avoid the burden of cholera in context affected settings or in settings that are potentially vulnerable to conflict.
Yeah, great question. There's a couple of different types of answers to that. I mean, the technical one, that's for the engineers, and they know how to do it well because they've been trained to do it, is just to keep the water and the wastewater systems separate. It's easier said than done, especially if they're understaffed, overworked, and the systems are decrepit. But that would be the goal. And any sort of humanitarian relief or Band-Aid solutions that go in that direction are indeed sensible. I mean, we have Reem Shomar on our call, and she can talk about Gaza, and there are issues of antimicrobial resistance which we might want to consider. But generally, keeping water and wastewater separate is a really good thing. So keeping the lines separate if you can, or treat the heck out of it with chlorine. Secondly, it's interpretations of IHL. For what it's worth, if international humanitarian law, the rules of war, can offer any protection beyond the paper, then this knowledge that we have, and so that the data that Rowan and others are collecting, makes it more difficult to say we didn't know about the reverberating effects. And that's important because IHL talks about the interpretations of IHL suggests that reasonable reasonably foreseeable effects should be considered by targeters when they are choosing their targets and when they're conducting their proportionality assessments. So if cholera is not reasonably foreseeable because we didn't know there was an association or causation, then the attackers are exempt from that. But if we know there is an association, or certainly if there is causation, then the attackers are aware, and the effects are reasonably foreseeable, and so therefore they should consider those before they make the attack. And then hopefully the hope is that the attack or the damage to the water systems at least won't occur.
Thank you, Mark. Very useful. I'm going to change the sequence a little bit and move and stay with the global perspectives on cholera before going to Syria. So I'm going to call in on Danielle Latan from the Tufts University, who's a professor of civil and environmental engineering. Danielle has a background in environmental engineering from MIT and a PhD from the London School of Hygiene and Public Health. She's worked with the CDC and served previously as program director of the Ipswich River Watershed Association. So she was working a lot on issues of water and health. Danielle, welcome to the webinar. Perhaps, Danielle, you could reflect with us on some of the global best practices and strategies that can be implemented in context of conflict and that can help prevent cholera transmission, and which then later on we will explore their application or their non-existent applications in Syria. Perhaps, Danielle, you can comment?
Thank you so much for having me. Yeah, right. Thanks so much for having me. It's great to be here. When we talk about the kind of pillars of cholera control as laid out by the Global Task Force on Cholera Control, we talk about 5 pillars, and those are 1, oral cholera vaccination, 2, epidemiology, understanding where the outbreak is, and community engagement to understand how to work with the community to control it, laboratory capacity to test for cholera, case management and treatment, and then water, sanitation, and hygiene. We want those 5 pillars to come together to meet our objectives. And depending on the context, we can have different objectives. Our objective could be to eliminate cholera. That is the goal of the Global Task Force on Cholera Control, to eliminate cholera in a context, to prevent it, right? Or to control it once it's happened. So clearly, if you are in a context where you do have water and wastewater infrastructure, a clear way to prevent cholera transmission is to prevent that wastewater from coming in to your water distribution systems, right, to keep the chlorine running. And we do have outbreaks where we have seen infrastructure degrade. Zimbabwe is an example of a large outbreak where the infrastructure degraded and it caused an outbreak, right? Now we also have many contexts, DRC, other countries where there are simply no water and wastewater systems, where people are using surface water, people are using well water, and then we talk about potentially other measures to control cholera. So first we think about our objective. Do we want to eliminate, prevent, or control it? Then we're thinking about our decision factors. What's our context? What's the capacity and context? How is it transmitting? Is it the water system? Is it via latrines? Is it via food? What's our funding available? We think about our intervention context. Is it a humanitarian response, like a conflict? Is it a camp for displaced persons? Right? And then we think about our influencing factors. What's our wash and health systems? Are we able to target and map? And so when we think about either eliminating, preventing, or controlling cholera, we can be on a very large spectrum. At one end of the spectrum is thinking about meeting the Sustainable Development Goals and installing water and wastewater infrastructure and having safely managed infrastructure that prevents this contamination. And that's a long-term development strategy in order to eliminate cholera in the long term. At the other end of the spectrum, we may be in a humanitarian response or a conflict situation where, in fact, we have an out of control cholera outbreak and we don't have water and wastewater supplies. We don't have a operational health system. And what we're looking at is a much more humanitarian response where we look at identifying cases and providing case area targeted interventions around those cases, aqua tabs to treat water at the household level, chlorine tablets to prevent water that might be collected from a well or a surface source, kind of active case finding, trying to do some community education, maybe something like household spraying or household disinfection kits to kind of do environmental hygiene around the home. Those kind of case area targeted interventions can break transmission routes in contexts where we're not yet able to think about the long-term development infrastructure to prevent or eliminate the cholera. So I would say, depending on your context and those kind of objectives, decision factors, intervention contexts, and influencing factors, that tells us what we can do within those realms of vaccination, epidemiology, laboratory capacity, case management, and WASH to eliminate, prevent, and control the outbreak.
Wonderful. Thank you very much, Danielle. So with these three interventions, brilliant interventions, we now have laid out the global picture about cholera. What we will do right now is go to Nasser Mhawish, who is our Syrian surgeon, who is an experienced surveillance officer and public health specialist who works with the Assistance Coordination Unit, ACU, in Gaziantep, Turkey. He has an MPH and a really long experience in communicable disease surveillance in Syria and the region. Nasser, it's good to have you with us. For the rest of the discussion, we're just going to focus on Syria. And Nasser, I'm going to ask you to reflect on three dimensions. Perhaps we'll take each one separately. And I will ask Rowan, Mark, and Danielle to perhaps comment on each of those three dimensions, if they have comments, before we move to the second dimension. So the first dimension, Nasser, is that on September 10th, the Syrian government declared a cholera outbreak. Perhaps you could tell us a bit more details about this. In your work in the northwest of Syria, did you see cases before then? Did you suspect that the cholera outbreak was coming? What do you think contributed to this cholera outbreak, particularly in northwest Syria? But perhaps you can reflect on other parts, how it has evolved. So perhaps our first question concerns the epidemiology of resurgent cholera in Syria. Over to you, Nasser.
Thanks, Amran. Thanks for hosting and organizing this webinar. In a matter of fact, it's a complex of reasons that led to the current cholera situation in Syria. Unfortunately, this is a thing that has been anticipated for quite years from now. Since 2011, and it escalated in 13-14, where everyone was thinking that we may be struck by cholera in Syria, but unfortunately we could not prevent it when it came for real. Preparation and everything was there, but when it comes, it comes. And one of the main reasons was because the infrastructure everywhere, and I'm here talking about all of Syria, not just northeast or northwest, the infrastructure has been damaged greatly everywhere. The fear risen when cases were reported in Iraq. And from the epidemiological point of view, everyone was more concerned about northeast Syria because we know that there are some population movement between Erbil, Suleymaniye, and northeast. Unfortunately, the cases started to happen in areas under the government access and control in Aleppo, and then cases in Latakia, in Hama, and so on. After that, we started to see cases and detect cases in northeast Syria. And from there, we knew that eventually it will pop up in northwest Syria. So the first thing that led the road for it was the destruction of the infrastructure for WASH-related things. The other thing is, and it's related to the first one, is the weaponization of water itself. All the combatants are using this as a strategy, either to push for some negotiation gains or to do some on-land gains. And this has been a trend when we see always the attacks on healthcare and water sources and water stations before any big military operation by everyone, unfortunately. So what Mark talked about with respecting the humanitarian part of the right for people to have safe water was not respected properly in most of the areas. Another thing comes to that is the health and health-related management in general, where all is about life-saving approaches, whether it comes to health or WASH also. And unfortunately, with one of the forgotten elements, also related to food security and livelihood, where people are deprived from proper water for irrigation and agriculture, they are using whatever they can. And we saw that in different areas where the drinking water is safe, it's nicely chlorinated, and there is no cholera in it. But we find out later on that they are using sewage water for agriculture, which is the reason why it's spreading amongst those communities. So it's a big, complex situation that no one can say that this is the reason behind it and the other one is not. It's all of that all together. And it's, as you said, it's really sad to see it happening in Syria, a place where we used to have proper infrastructure and lots of surface water that we can depend on, but unfortunately it became the reason behind that.
Thank you, Nasser. I bet many of our colleagues listening in are asking themselves the following question. You know, we are now in the 12th year of the conflict, and you've said that we've been anticipating this for some time. Why is it so late coming? That's good news that it didn't come sooner and create big problems for the country and for the people and affected communities. But why are we seeing it so late in the game?
We had other diseases to play in the field in Syria. We had polio, we were having measles, meningitis. Diseases are popping up everywhere, communicable and non-communicable. It just needed the introduction of cholera into the area. And apparently we were lucky for quite a long time and not having it, but when it came, it hit greatly everywhere, and it hit very hard, unfortunately.
Thank you. Okay, our global expert, Danielle, Mark and Rowan, any comments on the epidemiology dimension before we move on? All right. If there are no comments.
I wouldn't mind. Oh, so go ahead, Danielle, please.
Okay, if I may ask each, because we still have other subjects for the interventions, the commentaries to be a bit brief. Over to you, Danielle.
I can go quickly. I would say I completely agree. We have expected cholera in Syria for many, many years. And the question of why until now, there was a lot of work that we and UNICEF worked on with numerous NGOs in southern Syria to look at chlorinating at each stage of the water chain for those people that still had access to water supply systems, which degraded over the past 10 years very much. Mm-hmm. You could chlorinate those water distribution systems. Trucked water replaced for many people those water supply systems. So trucked water went up significantly. You could work with the trucker organizations to chlorinate in the trucks. If neither of those works, you could chlorinate at the household level. And we saw really nice programs throughout southern Syria on that risk reduction management on those 3 levels. And so I'd say when those programs are not happening, and in northern Syria, we have quite a few displaced populations, it's a higher risk. And I agree. That it was just the introduction in that area that led to the spark.
Thank you, Danielle. Rowan, you wanted to come in?
That was basically it. Thank you.
Okay, all right. If no further comments, then we get back to Nasser. Nasser will have two sets of questions for you right now. One question relates to what has been done so far, and the second set of questions, I guess, will relate to where we move from here. So let us first examine what has been done. Can you walk us through what the response has been? What are the successes? What are the failures of the response to this date?
Okay. So far, under WHO, whole of Syria, and the working groups working there in different regions, and again, it's sad to see all this fragmented efforts. The working groups and the task forces are involved in the response mainly. It's mainly led by WHO and the clusters, and it covers the pillars that Danielle mentioned, from the communication, negotiation, surveillance and lab, coming to risk communication and community engagement, up to the case management, logistics, and finally for the vaccine. So it's been there. In theory, it's all is ongoing, the planning, looking at the gaps and trying to identify them all over Syria, not just in northwest Syria, but unfortunately, with the situation of the global funds diminished for all kind of responses, and having cholera as a regular thing that's happening around the globe, it was not supported that much. There is support, but it's very scarce, and it goes step by step, unlike with COVID situation where lots of money was poured in it because it's a new thing and no one knew how to deal with it. With cholera, no, it's more systematic and less money is poured into this kind of response. So far, we're lucky that the numbers are decreasing. Although we're having less than optimal reporting of the cases, but we did not register more than 50,000 cases all over northern Syria, northeast and northwest, with minimal number of fatalities. This is not because the cases are less than that, or like this number, they are much more, but this is what we reported, fatality and suspected cases. Other than this, with the case management, again, it's been basic, it's related to people going there, and it's sad to see also the stigma and people trying to manage themselves in non-cholera designated centers. For now, the numbers are decreasing. We're expecting that it will be going down more and more, but unfortunately, we will be hit again, most probably in the coming spring, summertime. So in general, I cannot say this is the optimal response activities, but at least it's there. Some coordination is done between the hubs. We hope that it can increase, but for now, it's just something to be done and nothing more.
Okay, thank you, Nasser. Our esteemed global experts, any commentary on your observations of the response? Because Nasser implicated not just Syria, but he spoke about elsewhere. You could possibly bring in other comparative perspectives on the response in Syria versus other settings. Over to you. Anyone wants to come in? All right. If no one wants to come in of our global experts on this point, then perhaps we could go to the chat and ask the question on behalf of Diana Reyes, who's the chair of the Syria Public Health Network, and like Ola and Karim, really another global health lighting star here. Diana is asking the question about the 2 million doses of cholera vaccine that have been provided to Syria through Damascus. She's wondering about whether they will reach the areas of greatest need. Nasser, would you like to comment on this?
Yeah, so 2 million doses officially were announced that will be delivered through the Ministry of Health, and they started the implementation in what is supposed to be the highest risk areas and the areas with the highest number of cases in northeast Syria. This means Deir ez-Zor, Raqqa, and parts of Al-Hasaka and Aleppo also. So northwest Syria will not be covered. It's expected that more amount of the oral cholera vaccine will be delivered through Gaziantep hub to the area. It's still in the pipeline. Some documentations were needed, but it will happen as we've been told pretty soon from now. The amounts are not sufficient. When we look at it, if you are talking about the target population, it's all people more than 1 year. So 2 million are just to focus on some regions and not everywhere. And I believe due to the scarcity of the vaccine globally, it will be the same for Northwest Syria. I don't think that it will be a big amount that will cover all the population. It will be just minimal, just to look at maybe the camps or some other high-risk areas, or the areas where we're having high number of cases. Again, the global situation is controlling the situation here that we are dealing with. It's not up to the standards, but this is what's available.
Okay, thank you. So our global experts, any thoughts with regards to cholera vaccination in the Syrian context compared with other contexts in which you might be working? What is your advice as a public health global expert on what is being done for a cholera vaccination in Syria, or what's being planned to be done versus what should be done? Over to you. Anyone would like to comment?
I can comment generally.
Would like to comment? Yeah.
Sure, I can comment generally. Thanks for that information, Nasser, on how the vaccines are distributed in Syria. I mean, I think in general you hit the nail on the head. The issue is there's never been enough vaccine to completely cover a cholera outbreak reactively in most countries. And on the other hand, some countries are in the way they approach the vaccination is doing some vaccination preventatively to preemptively protect populations who will be at risk. So in Syria, if I understand correctly, the main issue is actually defining in a very concrete way the most high-risk populations in terms of their vulnerability to infection, their susceptibility to infection during the ongoing outbreak, and their vulnerability, their access to healthcare that could be life-saving. So, combining some of that risk assessment together is how you get the vaccine. So that should, in line with Deanna's question, should trickle down to the actual populations who require it, but it will never be enough right now because the vaccine is normally in short supply. But we hope that the most vulnerable populations can be affected. And I think we've seen that in Yemen and other countries as well. There is always a prioritization exercise that goes on, and with one dose, it will give some decent protection for some time for ensuing waves of cholera. Thanks.
Okay, thank you, Rowan. Nasser, and then I'm hoping that Mark, Danielle, and Rowan will also come back again to say, okay, this is where we are today. We're dealing with an epidemic. We have some questions in the chat regarding the epidemiology, so we'll get to that at the end. But let us spend a few minutes talking about the next steps in Syria, in global context. So Nasser, what do you think in light of the trends you are seeing and what has been done so far, what would you like to see done in regards to cholera in Syria?
In general, there are short-term and long-term things that could be done. On the short term, the enhancement of whatever is available. I'm talking here about the lab capacity. I'm talking about surveillance itself. I'm talking about the basic case management, at least, and the activities related to WASH for proper chlorination, distribution of aqua taps or whatever is needed to the population, and more awareness amongst the population about the importance of avoiding the sewage water for agriculture and so on. So this is at the short term. On the long term, proper sustainable projects related to that. People started to tend for the sewage water for agriculture because there is no alternative. When you look at the networks and everything in the cities that are a little bit calmer than others, you see just the project that has been done and then no maintenance for that. All are looking for the life-saving activities and the short-term projects rather than the sustainable long-term with bigger impact ones. And it's understandable when you have a protracted conflict like the ones happening in Syria, the donors would be fatigued to continue with this kind of activities. So again, short-term and long-term combined, hopefully will manage to contain the outbreak.
Okay, thank you very much, Nasser. Our global experts, what would you like to see done in Syria in light of what's being done for cholera globally in other context settings? Over to you. Who would like to comment?
I can jump in for a bit. I think when we think about either eliminating cholera, preventing cholera, or controlling it, for many years, we were in a space. Well, pre-conflict, Syria was in elimination. It wasn't there, right? In the conflict, we're in prevention. And unfortunately, recently, we've gone to needing to control. I would love to see the interventions as Nassar is talking about, laboratory capacity, vaccination, WASH, that allow Syria to move back to prevention and kind of quash this outbreak. And I think that is possible with a set of these interventions on these pillars that can stop it to get back to prevention. And then over time, it's those long-term sustainable development that are the SDGs that lead us back to elimination. And that takes funding and political will. And right now we're in the cholera outbreak, and I'd love to get us back to prevention as the next step.
Okay, thank you, Danielle. Mark, would you like to comment?
Yeah, well, I could just say that, I mean, everything Nasser has said is 100% sensible, and he knows it from living it. I can't underestimate just how miserable it is to have cholera. And so let's also not forget that behind the numbers, there's a lot of misery in the, even in the way people succumb or suffer through the disease. And the options, short-term, long-term, preventative, curative, whatever, have been well laid out by Danielle and Rowan as well. And the issue then is not technical. I mean, we would know what to do. We could control it if there wasn't a war going on. And so then it comes down to, yeah, political will, but unpacking that, what is it more specifically about? Is it geopolitics? Is it disdain for different peoples? What ideologies are driving these people to continue all the suffering? And that's, of course, a much larger and longer game that's out of our hands insofar as we let it be. I mean, we also have to keep up that other element of, ending the war, ending the fighting one way or the other, so that the conditions for which cholera shouldn't even be passed can materialize.
Thank you, Mark. Rowan, would you like to comment too?
Sure. Just to make one small comment that I've seen generally that would be interesting to hear about in Syria. Just the idea that we have these cholera responses that are very centralized to capital cities or the main response organization or centrally in the Ministry of Health. And I think, Syria being a very specific example, in other countries, what's been useful is decentralizing, whether that's talking about preparedness and preparing districts and communities with goods and knowledge, as you were talking about training health workers and hygiene promoters, that is done in a decentralized way. Empowering them to act when there is cholera appearing in their communities is very challenging, but could be sort of the key moving forward. We have a lot of delays because of logistics in a lot of areas, and because of humanitarian operations being sometimes quite centralized versus being decentralized, getting into insecure areas and so forth. So I'm not sure how challenging that is right now in parts of Syria, but it's certainly a feature of humanitarian response that we do that would be useful in cholera in general and outbreaks in general. Thanks.
Okay, thank you. All right, we have a few important questions in the chat, but we have only 4 minutes remaining. So, what I'm going to do is to actually ask each of our 4 esteemed panelists to really reflect on one issue and perhaps one message in their final remarks. I'll give each of you perhaps 30, 45 seconds to give us your last words of wisdom regarding what's been taking place, or what needs to be done, whatever you choose to focus on, and the key message you like to leave this meeting with. Nasser, I'll start with you, and perhaps you could also reflect on one specific comment that's made by one of the colleagues, which is about why are we expecting to see less cholera. Over to you, Nasser. About 45 seconds, please.
Why we expect them? Because of the seasonality in general. This is a trend, aside from cholera, that we have been seeing in Syria for quite a long time. In wintertime, waterborne diseases would decrease. We start to see more of acute respiratory illnesses, and it started already a couple of weeks ago. And the numbers are supporting this, with less number of cases are referred to health facilities with acute diarrhea in general, because now we are looking at acute diarrhea. Any acute diarrhea case is suspected cholera case. Numbers are going down. The number of moderate and severe cases also is going down. So hopefully it will keep this trend, and we can do some kind of preventive measures that help not to have another cholera outbreak or a peak at the summertime. What we can take from this in general, the first one is related to the weaponization of water itself. We've been seeing this since 2011. We hope that proper advocacy and proper legalizations at the global level are done for this, in addition to the proper documentation of those attacks. We've seen that happening in attacks on healthcare with systematic approaches. I did not see it much for water. Other than that, what I mentioned about the sustainable long-term projects happening, hopefully with some kind of resolution later on.
Okay, thank you, Nasser. I'll go alphabetically. Danielle, 30-second closing message.
I agree with everything Nasser has said, and I would say at the global level, we're seeing a resurgence of cholera, as Ruwan said, that we haven't seen in over a decade. And this is not just Syria. This is happening across the world, and we will need to kind of beat cholera back globally.
Thank you, Mark.
Yeah, I think everything that's been said is sensible. I think certainly, if we could develop international norms against the use of water as a weapon, or elevated water to the same sort of status, theoretical protection that hospitals, health centers, and schools have in war, or at least the consciousness of people. When you bomb a water system, you're really likely causing a lot of misery. And maybe the second aspect I'd like people to remember is that of all these components of a system, people are the most important. So if there's any humanitarian response, yeah, pre-positioning, emergency preparedness, all that's important, but keep the people in place as well and sustain them and keep them able to respond.
Okay, well said. Rowan, last but not least.
Just like to end by saying there are some really good news stories coming out of when you review actual responses to cholera outbreaks at the local level, and we should be sort of mining those to understand how that worked. As in everything in public health, if something happened and it worked, you don't hear about it. So I think that's really important locally, and looking to communities and community-based organizations and how they actually responded would be really useful going forward. Thanks.
Thank you, Rowan. This is a terrific message of hope that we can close here. I want to thank the Syria Public Health Network for organizing this discussion. I want to thank our esteemed panelists for terrific interventions and insights. And I'd like to thank Ola Abara for organizing and conceptualizing this session. She made my life very easy by writing all these questions that I have been asking you. So credit again goes to her. And thank you all. And I hope you join future events of the Syria Public Health Network. Thank you.
Thanks very much.
Thank you, everyone.
Thanks. Take care.